and that's Dr. Jeffrey Smerage. Dr. Smerage.
Good morning, and I appreciate the opportunity to discuss and present some of the data that I'll be presenting a little bit later this morning at 11 o'clock. So on behalf of the Southwest Oncology Group and our collaborators, we have recently had the data from the SWOG S0500 study released. This was a randomized phase 3 study to test what we call the strategy of changing therapy versus maintaining therapy for metastatic breast cancer patients who have elevated circulating tumor cells at first follow-up assessment. So this is a somewhat abbreviated slide deck compared to this later this morning, but hopefully the highlights will give you some sense of the background. So circulating tumor cells are cells that can be detected in the peripheral vascular system, so essentially a blood draw to obtain these. And they're primarily identified as a result of epithelial markers. They can be found in a variety of cancers. In this case, we're thinking specifically about breast cancer, and there are actually multiple platforms that are being developed. For this particular study, we used what's called the Cell Search platform, which is the only FDA-cleared platform for circulating tumor cells, and the system was cleared for determining prognosis as well as for monitoring breast cancer therapy. Now, the Cell Search system isolates these cells initially through an immunomagnetic capture system, which is based upon the expression of the epithelial marker EpCAM. Once these cells are essentially concentrated through this immunocapture, they are then confirmed through immunofluorescent microscopy. And I have a partial screenshot from the actual instrument itself that shows what the instrument, what they would be looking at when they're evaluating this blood sample. And what they're doing is confirming that these are cells because they have a nucleus stained with something called DAPI. They're confirming that they're epithelial in origin because they're cytokeratin positive. And then there's another, I don't know if I can, another channel here that's CD45 to exclude any contaminating white cells. And finally, the technician who's reviewing these looks at the composite image to show that, in fact, it has the characteristics of a cell. Now, there are CTC levels when enumerated via this system have been shown to have prognostic value in metastatic breast cancer, and there are multiple publications to this end. The primary study or publication that led to the SWOG S0500 study was published by Dr. Cristofanilli and colleagues in the New England Journal in 2004, and I have a little bit of the data from this. So what I'm going to actually focus on specifically just for time purposes is women with blood samples that were drawn at first follow-up. So they've started therapy, they come back for their next visit, and then they get another blood sample drawn. And for those patients who have, here we go, have elevated cells at first follow-up, the time to progression, clinical progression, was 2.1 months versus 7 months for those that had low cells, less than 5. And it was this 2.1 months that led us to hypothesize that those patients were likely to be on ineffective therapy. So the concept was that we'd be able to identify these patients early, switch them to an alternative therapy with the idea that they would benefit from that early switch. That way they would avoid unnecessary cumulative toxicities from a therapy that presumably is not working, and also would potentially allow them to then switch to another therapy which might improve the odds that they would be on an effective therapy. So the schema for this study is a little bit complicated. The primary study is actually down here in the lower right-hand corner. These are patients who have elevated cells after one cycle of therapy, and they're being randomized to either continue the therapy that they started with first line, or to switch immediately at their second line of therapy, their second cycle of therapy, to an alternative chemotherapy. So all of these patients were registered. They had a blood sample drawn at baseline before starting the first cycle of therapy, and those patients who had low cells, and low is less than 5, were observed on what's called Arm A. For those patients who had elevated cells at that baseline time point, went on to have a second blood sample drawn after one cycle of therapy at the 3-week point. And for those that had converted to low, something I like to think of as a CTC response, They were then observed on what's called Arm B. And then finally, those that remained elevated, as I've mentioned already, were treated on the randomized arm, which is down again on the right-hand side. This was designed to recruit 120 patients to the randomized component of the study, and this would provide 81% power to detect a 70% improvement in overall survival with a two-sided alpha of 0.05. This is the data for the randomized component for overall survival. And as you can see, there is no difference in median overall survival or overall survival in general between these two randomized arms. The median overall survival for both is 12 months. The hazard ratio was 1.0, and obviously a non-statistically significant p-value. Similarly, very little and no statistically significant difference in progression-free survival. So in arm C1, which are those patients who maintained therapy, which is in blue, the median progression-free survival was 3.5 months. For arm C2, which was the change group, it was 4.6 months. This was equated to a hazard ratio of 0.91, and it was a non-statistically significant p-value of 0.61. Now, what is probably the most important result of this study is actually a comparison of those three arms. The A arm, which was an observation arm, those were the patients who had low cells at the beginning before they started their therapy. The B arm, which were those patients who converted to low after one cycle of therapy. And then finally to the combined C arms, which were those patients who remained elevated after one cycle of therapy. And here, these CTCs are highly prognostic. If you look at the patients who had low cells prior to starting their first-line chemotherapy, the median progression-free survival, the median overall survival was 35 months, so essentially 3 years. In comparison to the green line, which is the randomized group, who had elevated cells after their first line of therapy, their median overall survival was only 13 months, so just over a year. I think it's also notable that if you look at the group that had low cells at baseline, more than 25% were still alive 5 years after starting first-line therapy, compared to 75% of the patients who had died after just over 18 months if they were in the group that had elevated cells after one cycle of first-line chemotherapy. So the summary is that changing to an alternative chemotherapy after one cycle does not improve overall survival or progression-free survival for patients with metastatic breast cancer whose CTCs don't decrease to less than 5 after a single cycle of first-line chemotherapy. Now, it is important to note that this study was not designed to detect benefits to chemotherapy, so it would not be a correct assumption to say that these patients derived no benefit from chemotherapy. We actually can't conclude that from the design of this particular study. Having said that, this population whose CTCs don't fall to less than 5 after one cycle of first-line chemotherapy are clearly at high risk based upon that finding. And that might influence treatment choices, including the possibility that participation in clinical and translational trials of novel and maybe even targeted therapies would be appropriate early in this patient population, where you might wait longer in patients where the prognosis is considered better, and you might stay with more of the standard currently approved drugs. I've sort of spent a fair amount of time on this next point already, but essentially these are highly prognostic. If you're low at baseline, the median overall survival was 35 months. If you're high at baseline but convert to low, it's intermediate at 23 months. And finally, if you're high at both time points, the median overall survival was 13 months. I think it is notable that at the time this study was initiated, the technology really only allowed the enumeration or counting of these cells. In the time since the initiation of this study and today, we now have the ability to do much more in terms of molecular profiling of these cells, whether it is looking at protein expression, RNA expression, looking for genetic mutations in these cells, even processes such as FISH are all possible now in these cells in ways that I hope will lead to better ability to predict the appropriate treatment strategies for these patients in a way that simply counting cells doesn't appear to do. So with that, I think the primary acknowledgement I'll make today, at least this morning, is just to acknowledge the patients who we're willing to participate in this study. And with that, I thank you for your attention.
Then we're ready for questions then.
Kate O'Rourke, Clinical Oncology News. I'm wondering in the community how many breast cancer clinicians are using circulating tumor cells and the cell search. What is the current use of this?
I actually don't know the data on usage. I can't answer that question. Certainly they are being used, but I don't know how to quantify it, and I actually don't know the numbers.
Crystal Fenn with my page today. My question is, will there be another trial using the circulating tumor cells in that more nuanced way that you were talking about with molecular diagnostics and things to try and redo a strategy like you've done but targeted treatment strategy, or is this it?
So the simple answer to your question is that on a smaller scale, the answer is already yes. On a larger scale, meaning at the level of cooperative group, I think that remains to be seen. I will tell you that, now this is beginning to be less me as a SWOG representative and more as a member of the University of Michigan faculty. We have a study that's recently completed where between the University of Michigan, MD Anderson, and UT Southwestern, we were looking at HER2 expression on primary tumors, metastatic tumors, as well as on circulating tumor cells with matched samples across in each of those patients to try to understand whether or not these circulating tumor cells might help us predict which patients have HER2 positive metastatic disease without requiring a biopsy of that metastatic disease, or at least repeated biopsies of that metastatic disease. We have another study ongoing at the University of Michigan that is looking at markers of estrogen signaling. And in this particular case, it is not directing therapy, but rather the assay is being run prior to starting hormonal therapy for metastatic disease and then being repeated as that patient is being treated on that hormonal therapy. And that will then look to see whether or not the markers that we selected to look at estrogen signaling predict who has a response to that therapy and who has better outcomes. So that's an example of biological markers, in this case related to estrogen signaling, that may actually help us understand who would benefit from further hormonal therapy. So a common question, you've started somebody on first-line hormonal therapy of any agent, the patient then progresses. What should the next therapy be? Should it be more hormonal therapy because they're going to respond to more hormonal therapy, or should the next therapy be chemotherapy because in fact their cancer is resistant, as an example of the kind of question that might help us to address. Now obviously these smaller studies need to have positive results in order to move forward to larger studies, and I guess I'm optimistic that in fact that's going to happen.
We need to move to the next speaker to stay on time.
Okay. Well,